Hi, I'm John Mascarenhas from the Icahn School of Medicine at Mount Sinai in New York City. The question is posed to me today is, should we reevaluate spleen-related endpoints for clinical trials in the evaluation of MPN-directed therapies? My feeling about this, which I think is shared by many in the field, is yes. Spleen endpoint has been an important endpoint set early on with the development of JAK inhibitors, namely ruxolitinib, as a primary endpoint and a means of gaining regulatory pathway approval. However, splenomegaly is only a portion of the disease, and there are many other endpoints and aspects of the disease that warrant consideration, such as symptom, anemia, and importantly, prolongation of life. So in 2020, I would like to think that we could move beyond spleen reduction as the sole focus and also have considerations surrounding spleen reduction in the second line. So for example, therapies that offer a spleen reduction of even 10% have been shown to associate with improved symptom burden and even outcome survival. And in the second line setting, a spleen reduction of 10% or even a high bar of 25% should be reconsidered by those regulatory agencies and even companies developing drugs as a meaningful endpoint for a second-line therapy after JAK inhibitor failure. Also, including duration of spleen reduction is important because if one attains a spleen reduction and then loses it quickly, the clinical meaningfulness to a patient would not be the same as one that endures spleen volume reduction for an extended period of time. So I think there are still a lot of considerations for spleen volume reduction. I'll always point out there's nothing magical about 35% spleen volume reduction, and that one needs to be more encompassing, I think, when evaluating novel therapies, particularly novel non-JAK inhibitor therapies, in which the benefit of that drug may be beyond or different than spleen volume reduction. An example of that would be imetelstat, the telomerase inhibitor, in which phase 2 data would suggest an improvement in overall survival despite a modest spleen reduction rate of 10%. So in studies like that, a endpoint for a regulatory or a registration trial would be survival. And for many patients, survival would trump gaining a spleen volume reduction beyond 10% to 35%. Those are aspects that we as a community and as clinical researchers, but also as patients, have gotten together with the FDA and discussed and are moving forward now in a new era of drug development.